So on that topic of going out of the clinician world and into the research world, anything exciting to you, clinical trial wise, that you're, watching in terms of what we could see in the future?
So let me speak broadly first.
Sure.
So it's kind of the same topic that we talked about before. What's the utility, or what are the different areas besides, initial staging or biochemical occurrence, for PSMA PET. I think that we may be able to look at response like other diseases have been able to look at, and maybe can get faster drug development. So that's something just generically that I'm looking forward to, whether it's another AR targeted drug, a novel AR targeted drug, a novel chemo, novel immunotherapy, et cetera. Because PSMA is something that is there on most prostate cancer cells, and if there's less that is there, having nothing to do with specific PSMA expression, just a lower volume disease, I think we can see that, and that's beyond PSA. It's incumbent on us, clinical trialists, to insert those in multiple clinical trials, and there's a cost that's associated. Hopefully we can get that out there. Prostate Cancer Working Group 4 is in progress, and hopefully we can get that out there and have it built into clinical trials, and that's the future. That there's never a place for CT MRI bone scan, but hopefully it's going to replace that a lot. So anyway, that's one area specific for imaging.
Really is exciting times in that regard.
Yeah. And then there's a as a target, as a therapeutic targets, we have one drug approval. I think that there is room for more. There are 5 phase 3 trials of which I'm aware, and a number of other phase 2s and phase 1s that are there. And those are just for the radio-labeled agents. Actually, even more specific, that's just for lutetium-177. So there are other betas that are out there. There are alphas that are now in the clinic, and there's Aujs that hopefully will come. And then beyond, radioactive particle, radionuclide therapy, we can use it as a self-service target for drugs, such as antibody conjugates, for immune system, so whether it's bispecifics or CAR T cells. I think that we can exploit the somewhat selectivity of PSMA and use it for a lot of different therapeutics.
It can really open a lot of doors. And a lot of what we talked about are advanced prostate cancer and utility of PSMA or PSMA imaging during advanced prostate. Is there any thing that you're thinking of using this, let's say at an initial prostate cancer diagnosis, maybe in the local setting?
So absolutely, I've used the term clinical localized forever, because something that's high risk, classically high PSA, at least in grade group 5, positive BRE, et cetera, we call that high risk. Not because it can't be cured with a knife surgically, it's a lower chance. So is there a cell that's outside the prostate, right? So now that we have a higher sensitivity detection tool, we can see that, this exact same patient, all of a sudden we see extraprostatic disease. Doesn't mean that that person would not benefit from local therapy, but more clearly in my mind needs something that is a little bit more. So, just with the existing therapeutic tools, hormonal agents, plus surgery, plus radiation, et cetera, that is something that's is today, really. And then, I think for the future, it may be more potent what we have, so for metastatic disease, we're now using triplet therapy for some patients, maybe that, and that triplet therapy is way more effective in that, castration sensitive, hormone sensitive, non-castrate setting, those are all synonyms, than it is for CRPC. So years rather than months. Moving it earlier, are we going to see cures in combination with surgery, radiation? Maybe, and this will help us determine that. And then using, if we can see it some of the time, maybe we can treat it some of the time effectively. So, I don't think that lutetium or a beta is necessarily the best therapeutic tool that we have for micrometastatic disease, maybe low volume mets, but not truly micrometastatic, but some of these other drugs or immune therapy or alpha or Auger emitters may be. So, that quote high risk that we can see, we can do something now. That quote high risk that we can't see. So PSMA PET is not perfect. It's going to miss, some disease. Actually, when we look at microscopic lymph node disease, 40%. We see, i.e. 60% we miss.
Right.
You know, that's it tells us there's something that's out there. So, you know, I think that hopefully in the not too distant future, it's not going to be next year, but sometime down the line, maybe, you know, those that walk in the door with a PSA of 20, you know, Gleason grade group 5 palpable disease, we can cure them, not just with the knife only, but in, you know, in combination with some additional therapy.
Well, what is the sensitivity and specificity and the predictive values of PSMA?
So, you know, it depends in the setting. So I gave you that 40%. So that's, you know, there's not a lot, there's not huge numbers of patients that have pathologically proven lymph node disease, just because it's not the vast majority of patients that we see out there. So, you know, there are patients that walk in the door with high-risk disease and we see Mets. So that's going to be a little bit different. We're not necessarily, you know, we're doing studies like, you know, these SWOG 1802 looking at what's the utility of prostatectomy with metastatic disease. But ignoring that, you know, the available data is that sweet spot for negative systemic Mets, but then go to prostatectomy and have lymph node positive disease. So anyway, the numbers are not so large. But interestingly, the two large trials that led to the approval of the two agents, PSMA-11 and DCFP-YL, showed the exact same results in this setting, where about 40% of that microscopic lymph node, you know, pelvic lymph node disease that was seen at lymph node section was imaged, and that, you know, much lower than with any, much higher than is seen with any other imaging modality. But it also points out that a PET scan, even with a highly selective cell surface target, is not the same as a microscope that can pick up single cells.
Right.
So it's a major improvement, but, you know, it's not quite there, you know, to pick up everything. I think that, you know, there's some interesting data that really first came from Europe, and now it's coming in the United States. This is, I think, most helpful when there's a high suspicion or even a positive PET. You know, so the UCSF data pointed out, UCSF, UCLA combined, pointed out some of the positive PSMA PETs that were called negative at lymph node dissection, or a false positive, were really probably true positive, just missed at resection or biopsy. So the combination of PET imaging with probes, intraoperative probes, increase the yields, you know, particularly now that we're seeing these, you know, lymph nodes at what I would call weird places, at least weird, you know, traditionally perirectal and things that we wouldn't have seen before.
Sure. Yeah. I mean, I think what we learned, I mean, what I think, you know, talking with you, you know, this is a start. We're moving towards very exciting things. We're not quite there yet, but this is another very interesting thing I think every urologist needs to be following and needs to be involved with. It's been really awesome talking with you and getting your perspective.